I just believe that healthcare is a human right. Health equity to me means if they don't have the ability, if they don't have the access, if they don't understand or have the education to receive that healthcare that is their right, that we have to provide tools to be able to get them the care that they deserve. So this group is a community-based steering committee of just community members who care about healthcare, care about the health of our community.
When you're looking at health equity, you're really looking at what I feel like ministry is. But God said, when you have done it unto the least of them, you've done it unto me. So this group is ministering to the needs of not just the community, but what God has called them to do. And that's ministering to Him, as well as ministering to the people.
Equity for me is an opportunity for all. It gives you access, you get good insurance coverage, and education.
I've realized working in the medical field that a lot of people don't know a lot of things. Things that I think, or some people think is just common sense, to them, they don't know about it. But since I had a little schooling, it makes sense to me, but to them it doesn't. So I've always wanted to educate the people so they understand.
If you're not aware and you don't understand, you don't know what to ask for. And you just can't rely solely on somebody else to tell you. But with the knowledge, with the awareness, with the understanding, you're able to now not only have the skills to participate in your healthcare, but you also have the knowledge to be able to say, well, these are treatments that you haven't told me about. I would like to know about that. Is this something that's available or appropriate for me? You know, because we're not the healthcare providers, but what we are able to do is provide you with the education so that you can ask those questions to really get the best outcomes.
Right now we're on the project of prostate cancer and the disparities here in the community. Knowing that in Iowa, alone it's one of the highest here for mortality rates.
I was a little bit shocked to learn about that. I would figure maybe like colon cancer or lung cancer, but prostate cancer being like the number one for Black men, I was kind of shocked because I have a son. And if I can take in that information as he gets older, then you know what to look for, you know what to ask, and you know what to do. I got brothers, uncles, and all of them, like, they don't ask those type of questions and they don't know. So if I can take all that information and pass that along, that'd be awesome.
I believe that if we educate the community and we go to the places where they gather, where community members gather, that is where we're gonna make the most impact.
You know, especially growing up, you can see where the healthcare is, where if you have money, you can buy anything. You can buy more time, you know, but the people who don't have much, they need help, you know, and I wanna be there to help.
So this wonderful steering committee is made up of 9 members, and we are very lucky to have 5 of them with us today and 4 of them up here on the stage. I will tell you their names, but then we'll let them introduce themselves as they present. So please help me welcome Miriam Tyson, Lischelle Oliver, Tiffie Greer, and of course, Georgia Hodge. Thanks for being here.
Well, good morning, and thank you for coming. I'm not supposed to touch the mic. That's what I've been trained. Don't touch the mic. Crazy stuff happens. Anyway, all right. So my name again is Miriam, and I have had an opportunity to work with these beautiful ladies and Reverend Cedric, who decided to let us do the honors, but we won't let you out next time. This has been a great opportunity for each of the members on the team. Many of us have issues with cancer, whether individually or family members. But we didn't really know that much about cancer. But we've been working with the University of Iowa and the Cancer Consortium, and it has been an eye-opening experience for us. So we said, okay, to develop and forge ahead with a plan, our committee, steering committee, reached out to our partners that I just mentioned to provide cancer statistics for us. The University of Iowa team provided us with information on incidence and mortality rates for cancers by race and cancer type in Iowa and in Black Hawk County. So our first slide, we're going to look at the incidence and mortality rates for all cancers by race in Iowa from 1995 through 2019. And if you noticed that the incident and mortality rates per 100,000, and we did that for the 4 slides that I'm going to show you. So the first one, as you can see, that the incident and the mortality rates are higher among the Black population compared to the white population. But it has narrowed in recent years. And also, the mortality rate is also higher among the Black population compared to the white population. So you can see both of them started in 1995 through 2019. We've had some ebbs and flows, some ups and downs, but it's narrowing. Now, one of the things when we looked at the slide, we did not look at any reasons why, because we really need a study for it. But the Iowa Cancer Registry, we got the information from them. Next slide. So, incident rates by cancer site and race, Black Hawk County, from 2015 through 2019, that shows that the Black population has a higher rate of prostate, lung, colorectal, and liver cancer. All right, next slide. Right now, this graph shows the mortality rates by cancer type and race in Black Hawk County from 2011 to 2019. And it shows that the Black population has higher rates for all the cancers shown. Next one. And this is my last one. We just set the stage for you. So we have top 4 cancers, incident and mortality rates by race in Iowa and Black Hawk County from 2011 to 2019. And as you can see, the spike, we have breast cancer, we have prostate cancer, and look how high the prostate cancer is. And that was a surprise for us, by the way. And then lung cancer, as you can see, Black population, there is 94 and 60, and that's pretty high. So we just wanted to share that stat, and then Lischelle will tell you a little bit more. But we're using the stat as a framework for us to pursue what we need to in Black Hawk County. We couldn't just go out there helter-skelter and say, oh, I think this is it, that's that. So we got a lot of stats. You're lucky you haven't seen all the stats we have gotten. We just thought we'd just give you a snapshot. Thank you.
Hi. Oops, that's a little loud.
My name is Lischelle Oliver, and I will be talking about the causes and the racial and ethnic disparities in cancer experiences and outcomes. I will be talking here about the distrust in the Black community about the healthcare. So anybody heard of the Tuskegee experiment? Okay. So those of you who don't know, this is a study that was done in Macon County, Alabama, in the 1930s. So there was a widespread of syphilis going around, and researchers wanted to do a study on it, or try to find a treatment for syphilis. So they did it in that county, and they did it with the study. The name was originally called the Tuskegee Study of Untreated Syphilis in the Negro Male, also known as the Tuskegee Syphilis Study. It was funded by the U.S. Public Health Service, and their criteria were crop shares, Black men 25 years and older, and they were told that the study was to help them how can I say this? They told them that they had bad blood and that they didn't go into detail what this was. You know, down in the South, they would be happy to get medical attention, you know, and that was one of the incentives for them to do this study, was to receive free medical exams, free meals every time they went to their exams, and burial insurance. I know you guys like burial insurance. That's kind of crazy, right? But I'll discuss that in a little bit. So they took 600 men, 399 of those men had syphilis. I know people think that they were giving them syphilis, but no, these researchers knew they had syphilis, and they took them and gave them these incentives. And like I said, down south, they didn't have much, and that was gold to them to get medical attention. And they told them that with the bad blood, they were going to be able to be treated. Well, boy, were they wrong. So they had this study. They found out, like, about 10 years, 11 years later, they found a treatment for it, right? So they found a treatment. You would think that they'd go back and go treat the people who they had with the syphilis, right? No, they did not. In fact, they did not give them treatment, and they proceeded on doing a research on them, and they wanted to do this research until they died. Well, 10 years after that, they found the treatment. It was broadcast in the newspaper of what they did. And so the families of these people they didn't know anything about this. They thought they were going to be treated, but in fact they weren't. And at this time, next slide. At this time when it was published, 28 participants died of syphilis. 28 participants had died of syphilis, 100 died of related complications, and at least 40 wives infected and 19 children contracted the disease at birth. So that's pretty harsh. So after this whole study was done, the trust in the Black community had gone down because they were told that they were going to be treated. So that's where, I'm not saying that's where all the trust came from, but this is just an example. Next. So I will be just going off, healthcare shortages. I work in the medical field, and in this, there's lack of physicians, you know, with a large population of Black and brown people. Well, in these communities, if you want to go to the doctor, you can't. You can, but there's going to be a longer wait time. With that longer wait time, there's things that happen, and then by the time you get to the doctor, you got something. You know, your primary care doctor is just for the generic things, flus and stuff like that. But if you have like a lump on your breast, they will refer you out to go see a specialist for that. Well, with these specialists, it's going to take longer to get into them because they have a criteria you got to use. And what about the people who don't have insurance? You know, with these specialties being far out, most of these people don't have jobs, and due to working, Black people get paid lower wages. So they're, they have to debate if they're going, they don't have cars, they don't have the support. They may have a ride to the doctor, but they may not have a ride going back. So these are the things you got to think about. So when it gets to that step, it's just the ball is dropped. So I'm just going to give you some things of the disparities that are happening in the Black communities, and this is coming from the American Cancer Society. Black people who have the highest death rates and shortest survivals of any racial ethnic groups for the most cancers in the U.S. Research has shown that African Americans experience more illnesses, worse outcomes, and premature deaths compared to whites. Cancer deaths in Blacks is twice as high as in Asian and Pacific Islanders, who have the lowest rates. Prostate cancer's death rates in Black men are more than double those every other racial and ethnic group. Black women are 40% more to die of breast cancer than whites, and are twice likely to die if they are over 50. About a third of African American women reported experiencing racial discrimination at a health provider visit. Living in a segregated community and our areas highly populated with African Americans have been associated with increasing chances of getting diagnosed with cancer after it has been spread, along with having higher death rates and lower rates of survival for breast and lung cancer. Thank you.
Okay, my name is Tiffie Greer. I have screenings, of course. So, which slide is that? You can go to the next one. Oh, I didn't see that. So I just have a couple of examples of recommendations for breast cancer and prostate cancer. I won't really read through all these, just kind of hit on some points as far as like the recommended guidelines for breast cancer, mammogram at 40. And decision-making as far as being able to know this information and being able to speak with your providers to kind of bring those type of conversations up. Whereas I work in the medical field also. I have seen breast cancer in women that are way younger than 40. And having conversations with your provider saying, hey, I'm checking, I want you to check, just knowing those type of things. Not every provider brings that up. Family practitioners, kind of, but not really. Because I see family, OBGYN, I get more of that information from my OBGYN than I do my own family practitioner. So, next slide. Prostate cancer guidelines are not 100% because with prostate cancer, which we have realized now in Black men is higher and the mortality rate is higher. They say men aged 40 to 54 is when they should start testing for prostate cancer, where how many of our Black men actually know, hey, prostate cancer, how do I test for it? A lot of them think they just do a rectal exam, which is not true. So not very many of them will come out with that type of conversation with their provider because they don't have that education and knowledge to know, hey, it's just a blood test. Next slide. Go to the next one. And that one. So in my, from what I've learned in my field, screening suggestions for our African American men and women is to know your risk factors. Age, race, family history, you need to know that type of information. And let your providers know, because some providers don't really take that information. Hey, I go see the nurse, she said, hey, you got a family history? Of course, okay, what is it? That's it. They don't bring that type of information to the providers. So being able to know your risk factors, family history, and knowing how to initiate conversations with your providers, whether you start with your family doctor and say, hey, refer me to the next provider that will, take the proper steps to make sure that our health is going in the right direction, because that does not happen. And for providers, being able to know your patients, talk to your patients, kind of getting more comfortable with race,
cultural background and knowing that risk factors for African Americans are a lot higher in other races, because some of them I think they don't know, but don't know and really don't know how to initiate that conversation with their patients of color, Black people, even other races. But I don't think there's a whole lot of providers that really kind of know, but I think some of them do. They just don't know how to bring that conversation in, and neither do our Black people as well. So that's all I have. Georgie, take it away.
Hello. Now, from all we've heard so far, we've heard about all the disparities and things that are going on with people of color. So how or what do we need to do to make this better? Community outreach. Community outreach does not have defined lines and guidelines like the statistics for mortality, incident rates and all that. So we have to go out into the community. And if we go out in the community, I think of it like going down a winding road. You never know what you're going to meet at the next curve. You may have this population and they need certain things of certain educations, but as soon as you think that you've overcome that obstacle, you run into something else, right around the curve. And also as you go down the path, you got hills on the side of other things that they may be facing as far as family issues, economics, transportation. So all of those things are included in community outreach. So the first thing we need to do is education. Education is about talking about, giving them information about the cancers, explaining what the cancers are, the signs and symptoms of cancer, and also the screenings, what screenings are available for the various cancers. And in the screenings, there's a certain age, but then we also have to teach them about knowing your own bodies. For example, we were saying that certain ages that you start breast cancer screening or prostate screening. Know what to look for in those things. For breast cancer, a woman should always examine her own breast. And then if you find something different during an examination, you know that, something's not right, and then go to the doctor. I am a breast cancer survivor. I was not of age to have a mammogram, and that's how I found mine, through a self-breast exam. So those are the types of things that we need to let the community know in community outreach. Also, we need to talk about our diet, education, eating healthy. They may not prevent us getting cancers, but they may reduce our risk of getting cancer. And so these are just some of the things as a community outreach person we need to do to help decrease the disparities of cancer. And when we are doing this, we have to know that every segment of the population may be different, and we have to reach that segment according to where they are. Some of the population may have some education, so we may not need to tell them as much. Another segment of the population may know nothing, have no information at all, so we have to reach them at their point of need. And so that is part of health equity, being sure that we reach whoever we're outreaching to at their point of education. And so these are just some of the things. And after that, after we've educated them and they've gone to the doctor, we have to be an advocate, because the most important thing for a person in their cancer journey is helping to make their own decisions so they feel comfortable with whatever health journey they're going through. A lot of times, people go to the doctor, they're diagnosed, and the doctor will tell them, okay, do this. And the person says, okay, but then they're still confused as to why am I going through this, and what am I going to expect? And so as an advocate in community outreach, we help the person to understand their diagnosis, to understand whatever information the doctor gave them, and to help them make their own decision. Because if you're involved in your decision making, you have an understanding of what you're going through and an understanding of what to expect from whatever treatment that you receive. I have worked with people. For instance, one person was diagnosed with prostate cancer, and they didn't know what to expect. Another one had pancreatic cancer. They told them that there's no surgery options, nothing they could do, but yet they told them to take chemo. I said, well, why are you taking chemo? I don't know. And so 6 months later, they tested, and the chemo hadn't done anything. And that decreased their quality of life. So was that chemo, did he have a decision in taking it and knowing what it was going to do to their body? As an advocate, you have to we work with people to help them make those decisions to know how they want to live their life. And also as an advocate, you work with various age groups in the population. A lot of times you think of just working with the elderly because many times elderly have no family around them. And so we work with them to help them understand and just be able to support them. And that is very good, but elderly are not the only population that we're working with. Okay. And so you have to, in outreach, you have to know who you're working with, what age group, and how they're going to respond. It also could be a young person who has never experienced any type of health issue. And so you have to explain to them what the purpose of these health visits are and just to give them support. As an older person, that person may say, oh yeah, I've experienced this, I've been through this, but when a younger person is diagnosed with something, it's more, I don't know what you want to say it, it's more scary to them because they're at a young age and think they're in the prime of their life. And so we just have to know how to work with all age groups and know what to say. And so through community outreach, through education, we may help decrease the risk of getting cancer, and we also may decrease the rates of cancer. So this is just some of the work that can be done through community outreach. Thank you.
Thank you, everybody, so much for your presentations. We do have time for questions. We're going to grab an extra mic here, I think, so that we can ask questions. First, we'll just do a little jogging first.
Well, first of all, I want to thank all four of you. That was about the most eloquent description of cancer disparities I've ever heard. So thank you. So my question is, what do we do now? So how do we expand on the community outreach? What is the best way for us to get this message out there so that we can help reduce these disparities? And if it was an easy answer, I wouldn't have asked the question.
Well, what we're doing right now, getting out into the community, working with the community, checking with the community, going to places where people like that are. If there's a community center, go to that community center while people are there and say, hey, I'm coming to talk about health. I'm coming to talk about cancer. You have to meet people where they are to give them an education to let them know what's available.
Thank you all so much for such a great presentation. And just to build on the last question and your response, Georgia, I know they have public health programs in Allen College in Waterloo and at UNI up in Cedar Falls. How do you think, what would be the best way to get more people from your community to go into public health or to the medical
into the medical field so that our people, our Black population in cancer, don't feel so alone and so different than all the healthcare providers that they run into? And do you have any advice or strategies that we can help facilitate to get more people into public health in your community?
I think, in my opinion, is reaching out into our community, because you said you and I, Cedar Falls Health Department, how many of Black people in Black Hawk County are actually really in those areas? The majority of Black people are in Waterloo. So I didn't know that UNI and all that was in Cedar Falls and like Allen College. A lot of, I'm gonna say people like me, because when I graduated high school, I went to Hawkeye. Like, I don't know if maybe they can reach out more to like more community colleges, because after Hawkeye, I went to Kirkwood and got my medical assisting. I never even thought about UNI at all. And then there's a lot about nursing, not a whole lot with public health, in my opinion. So I guess just like getting that information out to us more in our areas where we live would be the easiest way to do that.
Yeah, I would have to agree with that. A lot of the Black population, they don't migrate out. They stay in their community. That's their safe zone. So you coming in and seeing where the gaps where you could help at, or when they have events that's posted, see where you can fit in. I mean, learn about what those events that they are doing, because a lot of those events, we're trying to educate our own people, because that, you know, and we do reach out to other organizations, but they don't reach back.
I think with you and I, part of it is how the university, how their infrastructure is. First of all, a lot of us don't necessarily want to go to UNI because the park, or even UNI, U of I, Iowa State, all the public universities, it's a bear cat to move around. So, and now we've had a lot of classes that are online. Now, I'm a continuous learner, so I'm everywhere. I mean, I go to everything, but I think what needs to happen is we need to collaborate with each other. So your folks don't want to go to UNI or wherever, but the professionals can come to us. The students can come to us. I'm currently working on a project. I'm bringing the symphony to my church in December, because people don't want to go all the way across town. I don't know what it is about the cultural relationship between Waterloo and Cedar Falls, but there are issues there. So they need to move out into the space, as some of the other folks have talked about. There are a couple of things, while I have the mic, I'll just mention this. We know that education is really important, but to the healthcare professionals in this room, when somebody of color, or just anybody, come to see you, you make sure you listen to them. Because what we're seeing in the Black community, I go to my primary care doctor, oh, just take something over the Walmart or Walgreens or whatever, over the counter. Sometimes you need to check further. You need to check in. I am blessed that I have really good doctors in Waterloo and in Des Moines. It's not an issue for me. Some people also come because they don't want somebody else to know that they're ill or they could be ill, so they go by themselves. When they leave there, they forgot what you told them. Now, when I got diagnosed with breast cancer, the second time around, I took my notepad with me. But when I went into that doctor's room, there was another person in there, and they said, you don't have to take notes. We'll take it for you. I think those were the two things that I got from working with people in the Black community and for myself. I'm just fortunate that I had really good doctors, and I do have a lot of connections, and I think that made a difference too for me.
And as I was saying with doctors and about the trust and trying to take anything from doctors, pills. A lot of the Black community don't like pills. I mean, especially if you explain it, but you don't explain it in the way that they understand. You don't know how many times my doctor has sent a prescription. They're like, I don't know what that is. I ain't taking it. And then that's where the disconnect, and then that's when it proceeds to something else. Bring it down a little bit. Bring it down.
Explain it to us.
Yeah,
like we don't
yeah.
know
So
what y'all talking about.
I know with my doctor, I have to come in after him, and I say, do you have any questions after him? Yeah. And I have to bring it down to them and say it in a way that they understand. And, you know, even like the way he comes about things, I have to say, he don't mean it like that, and smooth it out and tell them, you know, and they're like, you know, so they understand. And so that's what I picked up on the way, and I do educate them on the way as well, because doctors know doctor. Doctor talk and doctor lingo. They don't know how to bring it down. I think they do in a sense, but then they don't. Because then if you ask them, do you have any questions, they're like looking like, no, you know, because they don't even know what type of questions to ask because they didn't understand what you said. So
I could comment on like every single thing you guys said. But I think that I'll just go with the last thing. It's really about listening to people, and we don't listen to people, period. I mean, and that's everywhere you go, right? It's not just in the doctor's office, but really hearing what your concerns are. And so this is one of those 1,000% problems, right? This is not a 3 feet problem. But what you guys are doing in your community is, but for me, thinking about what we do, for instance, like Nathan Bennett, the thing I mentioned to you guys, if you go and look at it, Nathan is trying to figure out if he should get prostate cancer screening. And then he gets prostate cancer, then Nathan has to figure out what I'm going to do for treatment. So that's a resource sort of where you can go and look at that thing yourself and figure out what your questions ought to be. You know, something else I'm interested in is empowering people to ask the right questions when they get to the doctor's office and to be taken serious.
Absolutely.
And yeah, one study we did like way back in the day, it's been about 20 years, but we interviewed a whole bunch of women, focus groups about breast cancer screening, why aren't you going? We talked to Hispanics, Asian Americans, Black women, white women, and their Hispanic women, right? And everybody's concerns were pretty consistently the same. It was just, how do you talk about it? What words do you use when you're communicating to people? And that really is something that I send everything back. I review everything that comes through our division, and I just send it back. I'm like, that word makes no sense to anybody. So can you work on that again? Or in this community, that community. So to your point, too, about how can we hire people, you know, because I am the director in cancer control and I'm a Black woman, I'm sure I do a lot of things quite differently than someone else would do just because that's who I am. So how do we get more people? You know, I don't know if you guys knew this, there are undergraduate degrees now in public health. You know, you don't have to go to public health school to get a public health degree anymore. So, I mean, there's all kinds of things. And so the conundrum for me is, how do we get that information out to people? It's just what you said, you come to where the people are. And so at CDC, we're trying to fix the way the upper structure looks, y'all know what I'm talking about, and get more women in, because it's a male-dominated leadership sort of organization as well. The CDC is. Yes. So Black women, you know, we're trying to spice it up, but how do you get people to do that? Because who do we hire? I mean, right now it's like, who would I hire? Right. And, you know, somebody said that we got to educate kids. But I think we got to start in kindergarten if you want to know what I think. Because by the time they get to middle school, they kind of like run that road, right?
Right.
I ain't doing that. I want to do this,
Right.
kids. So I think we need to start, well, we can start in the womb if you could talk to them while you're pregnant. But, it's that kind of thing. But I'd love to hear you guys' ideas about how to do a better job with that, how to reach out to kids when they don't even know. It's a great profession. Public health and healthcare is a great profession.
That's a good question. You said, how do you go? Yeah, start having these doctors go out to the elementaries, having you guys always do career day when they're in high school. Yeah. Start that when they're in elementary. Get the ball, get their minds. Of course, in elementary, they want to be Superman and Spider-Man, Right. So if you get to talk, show them, I feel like that's a good start. Yes, absolutely. Right. Hello. Yeah.
Churches. Well, that was exactly what I was thinking about. Is remember? Well, you guys probably don't remember, but us older group will remember. As kids, you did field trips. You went into these different places, and viewed, and they talked to you, and they told you what they were doing. Same thing here. You've got public health. You got hospitals that have rooms, the X-ray rooms or whatever. Yeah. Call them up. Take the kids in as they're young and start building that health care thing with them. If they see this, how kids about machines. Oh, I want to work that, Right. And that will stay with them. So that's what we got to do. We have to go. Instead of waiting on everybody to come to us, Absolutely. We've got to go to them.
Right. Well, that's very good, because a lot of the times when we do reach out, a lot of the doctors don't have time. We invite them, but they don't have the time.
Well, then that's what you ask
and
them.
Then you have to go to the big people, because it's not the doctors who run these hospitals and stuff. You have to go to the big people. They don't want no conversation with us, but we do try. We do.
Yeah, but what I've always done is that when you reach out to them, you ask them for their schedule. What does your schedule look like at this time? In Cedar Rapids, I've never had that problem with anybody that has come to our lunches. I always reach out and say, are you available? And if I give them a date and they say no, I said, okay, but we would like for you to come and speak, and what time is available for you. So I go on their time. So that way they can't tell me that they had something else come up. I'm on your book, just like I'm coming to visit.
Also, when we're talking about youth, in some of the things I've done, I've involved the youth with my activities. I have had, with breast cancer walks and different health events, I've had the youth participate. One time we were talking about tobacco cessation. And my granddaughter, she listened. I didn't know she was paying that much attention. She said, can you take me by my dad's when we leave here? And she gave him the entire spiel about, about what was said during the tobacco cessation. So involving kids, the children, as you do these things, you never know how much they're paying attention, and they will spread the word.
Thank you all so very much for your presentation. It was awesome. As a black male in that age range, that prostate slide just really jumped up and down at me. What is it that we could do? What is it that collectively, individually, group-wise, that we can do to help more men my age become more aware of prostate cancer, since our numbers are so high?
Well, one of the things I think is getting into the community. It is so hard to get black males to come to events. So what you'd have to do is go to them. Find barbershops who are willing to participate, because all men are going to go to a barbershop sometime or another. Find those that are willing to participate and go there. Go there and set up shop and just educate them there. Or wherever you think men may be, or if they have basketball teams or associations, things like that. You have to go and meet them where they are.
So another one of the things that we are doing, well, one of our members is we're starting surveys for black men in Black Hawk County so that we can get that information. If they're going to the doctor, if they have primary care doctors, how are they getting their information as far as on prostate cancer and men's health? So far, I think we've done 67.
About 68, yep.
And of a lot of those, One of the main things was not very many of them have primary care providers. Like the older men, they do, but some of the younger ones don't. And the screening for it was one of the big things where they think, oh, it's this and it's not that. And the providers aren't really educating them on, hey, this is what we do for prostate screening. This is what we're doing for a different type of screening. They're not really letting them know or informing them the right information. So we're trying to get more information from our black men, but we going to them to get that information and reaching out to them. Because a lot of black males don't really understand or come to us, so we have to go to them.
I was just going to say what you can do is hold or conduct some kind of event where they just come and talk, but you got to make sure you have food. I think food takes care of a lot of that.
In the study that we are doing that Tiffie was just mentioning, knowing that we are having a higher mortality rates in African Americans, they're dying really fast. The cancer is really aggressive in prostate. And, our screenings are at 40, and that's just to standardize. But we think, and I know someone, or know of someone that has prostate cancer at 30 right now. So it's like, should we get tested earlier since it's more aggressive and we're dying faster than any other race there is? And that's why we want to get to talk, and we want to see where the disconnect comes from. Is it the doctors? Where are you getting your information from? Is it your friends, your uncle, your brother, anywhere, because we want to see where the disconnect, because we want to bridge that gap between you and the doctor and everyone. And if we have to be the go-between to do that, we will do that. That is a good question, and we actually have a flyer that has all the questions you need to ask your provider about that. Yeah, we should have brought some. I'm going to take your information when you get it. That's a really good question. Yes, we're actually currently doing a study on prostate cancer right now. Yes, absolutely.
Well, and I do have to say, too, that we really do need to work on educating. Remember when we were big on smoking? We were talking about not smoking and all of that. That finally got through. The U of I team had sent me some information where lung cancer among men has declined because I think we saturated the market with no smoke, no cigars, some of that. And I think we just need to do more of that because it does work. And to Georgia's point, the community outreach and education really does truly make a difference.
Right. And
what, Georgia?
Your symptoms, what you were talking about, to look for, they're not as prevalent as in men, like breast cancer with a lump. They typically do find them when you get a PSA done and a blood test.
Okay, we're a little over time, but this is so great. We're going to do 2 quick questions, and then we're going to release you to lunch. There's 2 lunch tables, same food. If you requested a special lunch, see Kelly Rollins at the table out here. But let's get 2 more quick questions in very quickly, and then we'll release you to lunch and talking to exhibitors.
Thank you, and I hate to be the person that's keeping us from lunch with the question, but I also wanted to say, great job. The work you guys are doing is yeoman's work, and it's so needed, so thank you again, and a great presentation. My question is this kind of work in navigation, I think Dr. Richardson had talked about it before, community navigation is where we all need to be. So how are you guys now taking your findings and putting that out there so other communities can learn from that? Are you looking at publishing? Are you looking at the impact that you're doing? Maybe it's through a survey like Malachi walked through, but what are your next steps in that form so communities across Iowa and the country can then mimic what the success you're having?
I'm going to look at Natasha, actually.
That's a really good question. Right now we're on the ground. We're doing the studies right now, and hopefully by then after we get the studies done, then I don't know from there. I think we were going to put it all together, put a presentation, and then you're on it. We're still there.
Well, one of the things that, and I was talking to Megan and the team, I think what we need to do is we need to start with the health professionals. We need to talk to them. We need to find out what their needs are. Because, it's easy for us to sit up here and talk about what they're not doing. Well, they got a life, and somebody says, well, they don't care. I think they do. They just don't have the time, or maybe did not have the training. They might live in a neighborhood where there might not be anybody of color in it. It's, so I think they care, so you need to talk to your doctors and ask them to have a dialogue. If that doesn't work, somebody is paying their way in that hospital or in that clinic. You go talk to them and you tell them, look, we got to have a town hall, or we have to have some kind of collaboration, education meeting. And if they don't do that, like we do with professors on campuses, you have a Call to Jesus meeting. There is also an assessment every year of doctors or anybody else. We all know we've been subject to it in our workplaces. But we got to put pressure on folks. But I just want to thank all the healthcare professionals, because I think they do care. I think doctors go home, nurses go home, and they worry about their patients. Give them a little bit of slack, give them a little bit of grace, but at the same time, grab them by the whatever.
And what we've been doing, we actually, just last Saturday, we held a thing at a church about, in the Black community, trying to educate them on the prostate cancers. And like we said, the people did not know anything. They knew that they thought it was a rectal exam, and that's why they never brought it up to no one. And so when we told them it was it's a blood test, they were kind of surprised. And we gave them a sheet that educated them what questions to ask when they go into these things. So that's what we are doing to educate the people.
Another thing for physicians is maybe if there's some way to give them diversity training, and that way they would know how to deal with you go to school and you get your education, you know about the medical part, but then you also have to know how to talk with the people that you're seeing. So maybe some type of diversity training to be instilled into part of their training as an ongoing thing during their career.
I'd like to say a little bit about our program at our church. We've been shut down because of the pandemic, and our program is called Body and Soul, and it's a health program. We have physical fitness. We teach about how to eat healthy, and we have a cancer doctor that has come several times and spoke with us, and that's Dr. Reed from Mercy Hospital in Cedar Rapids. So we're about to start our program back again and get it back up and flowing. And this is our pastor right here, and he's very energetic, and I'm quite sure he'll be there to boost us up and get us back going again.
So is that an invitation?
Sure. Yes. And so that's Mount Zion Missionary Baptist Church in Cedar Rapids. Mount Zion Missionary Baptist Church.
Okay.
And I'm the coordinator, Paulette Clark, so I can be reached through Lynn Jackson, the secretary. Okay. So no problem.
And I want to say that I love the work that you have been doing throughout the years, and you have made a tremendous impact. Your church has. Yes.
Thank you all so much again.